Global health is really embedded in the very fabric and even premise of the hospital. This hospital, Mass General, was founded on the premise that when in distress, every man is our neighbor. Some of you may know that before Mass General, you had to receive, the only way to receive medical care is through a house call. A private physician would come to your home and render care. That required two things. First, you had to have enough resources to pay for a private physician, and the second, you needed to have a house. The founders of Mass General came up with this revolutionary idea that when in distress, every man is our neighbor, and that we should create Massachusetts General Hospital to provide health care, the best possible health care, to everyone in our neighborhood, regardless of resources and regardless of whether they have a house. Today, with every part of the globe within easy reach of a plane flight, we live in a global neighborhood. And now more than ever, Mass General is leveraging its talent to reach out to our global neighborhood to find those most in distress, to provide the best quality care possible. And what I hope to do tonight is to illustrate how the mission of the hospital with respect to global health, and that's to leverage Mass General's 200-year legacy in medical care, education, and innovation, is improving the health of our global neighborhood now in our third century. But before talking about those three domains of work, I'd like to define what is global health. And the WHO came up with a definition that global health is an area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. This defines what global health is, or what it should be, or what it needs to be, but I don't think it really characterizes how we approach global health here at Mass General. As both a scientist and a physician, I believe that global health should be seen through the lens of our partners, who identify the most important public health challenges in the regions where health is in greatest jeopardy, and then we co-identify challenges with our partners. We build local capacity to deliver care, to educate the next generation of doctors and nurses, and develop scientific capacity to come up with innovative ideas to advance medical care around the world. Currently, Mass General is engaged in 53 countries worldwide. There are 22 clinical departments and centers at Mass General, and 18 of these clinical departments have formal global health programs. The reason the department chairs are investing in global health is largely because of the youth. In order to retain and attract the best and the brightest young physicians and nurses in Mass General, these young people are saying, I want an opportunity to engage where healthcare is needed most in the world. I want an opportunity to have a global impact. So our job at Mass General Global Health is to work with each of the department chairs and center directors to ask, what is your global health strategy and how can we advance the strategy? How did we get here? We got here through the same core purpose of every hospital, and that's to deliver patient care. And we've been involved in global health and delivering patient care in global health with respect to disaster response for nearly 100 years. On December 6, 1917, there was a munitions ship called LeBlanc that had boarded munitions from the US, was harboring in Halifax, Nova Scotia, on its way to Western Europe during the middle of World War I. This munitions ship had a collision with a second ship, which immediately ignited and created a tremendous explosion that killed 3,000 people instantly, injured 6,000, displaced 10,000, and leveled 2 square miles. News of this tremendous explosion disaster reached Boston almost immediately. And within 24 hours, the leadership of Mass General were loading up doctors and nurses on trains to go up to Nova Scotia to tend the wounded, to mitigate the injuries, and to save lives. This was Mass General's first international disaster response. And it's because of this response that the city of Halifax supports the Christmas tree that you see in Boston Commons every year, to say thank you to the people of Boston and Mass General to responding to us in our time of need. Over the last 100 years, Mass General has responded to pretty much every disaster that's ever occurred. We were at the fall of the Twin Towers, we were at Hurricane Katrina, we were at the earthquake in Iran, we were at the tsunami in Indonesia. We were one of the only international partners invited to Japan after the tsunami and the earthquake. We were at the hurricane in Indonesia. We were at the earthquake in Haiti. And then on April 25th of this year, most of our team was at a global health technology conference. And our cell phone started to ring. We knew something was up, and we learned that there was a 7.8 magnitude earthquake in Nepal. Our first job was to make sure that all of our Mass General people were safe and sound. Mass General Global Health has set up a system that, with literally thousands of people traveling to over 50 countries around the world, we can now track instantly and know where every Mass General employee is anywhere in the world at any time. At the moment of the earthquake, we had 10 Mass General employees in Nepal. We located everyone was fine. 2 of our employees, Renee Salas and Laura Phillips, were at the base camp of Mount Everest. They had already began evacuating the injured hikers and locals, triaging, helping care for people in the midst of the earthquake. Once we knew our people were safe and sound, we then activated our disaster response team at Mass General. We have over 100 seasoned disaster responders, and we began looking through our roster and said, this is an earthquake. What is our district? What is the type of surgeons, internal medicine doctors, pediatricians, anesthesiologists, nurses that we need to respond to the injuries of this disaster? We went down our roster. We said we may need you. We talked to the supervisors and managers of each unit and said, we're going to deploy. We need to figure out coverage. And within 72 hours, we had the first of 3 team of Mass General doctors and nurses on a plane to Nepal to respond and help with this disaster. Renee and Laura left and joined our team and became one of the first responders. We sent 2 more teams, and Mass General comprised over 10% of the international response to Nepal. We were very fortunate to partner with International Medical Corps, which provides the supply chain. They provide the transportation, logistics, the medications, the equipment we need. Mass General provides the human expertise to deliver that care, and together we can respond to any disaster anywhere in the world within 72 hours. This takes leadership. Here we have Hillary Cranmer on the left, a former 6-foot-tall professional basketball player who co-leads MGH disaster response with Miriam Ashkenazi, who's sitting right there. Miriam, raise your hand.
I'm also 6 foot tall.
In spirit, this is true. And Miriam and Hillary, they're very busy during disaster, as you can imagine. There's a lot to mobilize. But the most important thing is they're just as busy between disasters, preparing for the next disaster, by working with MGH leadership, working with MGH clinicians to make sure we're even better prepared for the next disaster. And through this training, both at MGH as well as partners throughout the country, they have raised disaster response to a new professional standard. And that's what distinguishes MGH disaster response from so many other of our peers. And is this value on education and training the next generation disaster response, the responders, that really distinguishes MGH. And MGH has a long history of education. Some of you may know that where we are standing right now was the original site of Harvard Medical School. There's MGH on the left, Harvard Medical School on the right. That is right here. MGH has always been the first and the largest teaching partner of Harvard Medical School. This is the place where Harvard clinicians learn how to practice their trade. And it's because of this emphasis on education that wins MGH as being recognized as the nation's, if not the world's, best hospital. So we would like to take this value on education and invest in what I think is the world's next major global health challenge. And this is cancer. There are over 500,000 people in Africa who die of cancer each year. And because we've made such progress in HIV, TB, malaria, and even maternal child health, 12% of all deaths in Africa are now due to cancer. But the most striking and the most difficult fact, though, is that 1/3 of the cancers in Africa can be either prevented or cured with existing technology. The technology that we have and medications and procedures we have on the ground. But only 5% of people with cancer receive any care whatsoever. The reason they don't receive care is we don't have enough people to deliver the treatments that we have available today. Let me introduce you to Dr. Becky Timbandarana. Dr. Becky is the single oncologist for a catchment area of 10 million people in Uganda, the Congo, Tanzania, and Rwanda. One cancer doctor for 10 million people. If you take that same doctor to patient ratio, that would be equivalent to 32 cancer doctors for all of the US. The Mass General Cancer Center has 350 cancer doctors just for the patients we care for. How do we enable Dr. Becky to care for 10 million people? Well, the first thing we do is we invest in Becky. If you're a doctor in Uganda, you finish medical school and become a medical officer, you have to pursue what's called a master's in medicine to pursue subspecialty care like oncology. A master's in medicine is sort of like a residency or a fellowship here in the US. But unlike the US, which pays you not very much, but pays you enough to get a small apartment and to go to work 80 hours a week and make ends meet, in Uganda, you not only have to figure out a way to make ends meet, you have to pay tuition for the opportunity to learn. 4 out of 5 doctors in such training programs will drop out because they simply have to feed their family. Friends at MGH invested in Becky and paid for Becky's tuition and a modest living stipend such that Becky could focus on her training and learn how to deliver cancer care. MGH has since invested in 3 more people like Becky, such that we have now quadrupled, or will soon quadruple, the capacity to deliver cancer care in this region. In all, MGH has sponsored 23 such people. You've heard about brain drain, about doctors and nurses leaving for better paying jobs elsewhere. Well, we find when we help people like Becky with their tuition and a modest living stipend of just a few $100s a month, that they adopt the public health mission of the institution. And of the 23 people that we have supported, only 3 have left. The remainder continue to support and live and pursue a public health mission. The second way we invest in Becky is by linking her to world-class expertise here at Mass General. On the left is Dr. Jim Cusack, who leads the MGH Uganda Cancer Center Initiative. Jim is in Uganda every 2 to 3 months, and Jim's done a great job at building support of Mass General Cancer Center folk, the clinicians here, to help support this mission, and brought on many people, including people like Marcia Brown, Fred Meyer, and others to support this initiative. And now we have over 20 individuals at Mass General. Pat Doust is one of our committed leaders who's leading the nursing initiative, who are bringing Mass General expertise to support cancer care for Becky and her students. So I said almost every month there's a Mass General clinician alongside Becky to help build capacity to deliver care. And the third way we support Becky is by giving her a physical place to work. When Becky started her outpatient chemotherapy unit, it was really a closet. In fact, it was a supply closet that we cleaned out, got the old supplies out, and Becky would give chemotherapy to 20 to 30 patients a day. The very sickest patients would be able to sit in the closet to receive their chemotherapy. With the help of 2 young 15-year-olds, Maggie Berry and James Mooney, they raised enough money over a period of a few weeks to not only turn that supply closet into an outpatient chemotherapy suite, but to build a 30-bed inpatient cancer ward. They raised this money in a few weeks, and we completed renovation in over 6 weeks. And just this picture I took 4 days ago. And we look forward to opening this up in the next week. Such that with investing in Becky, investing in her students, investing in the nursing staff, and providing a place to work, we are already providing a level of cancer care in this region that no one thought was possible before. But the MGH Cancer Center is even more ambitious. This is great progress, but this is not enough. The MGH Cancer Center is working with the top leadership of Uganda to define and build a comprehensive cancer care that not only provides inpatient, outpatient chemotherapy, but provides truly comprehensive cancer care for medicine, for pediatrics, includes surgery, includes nursing, includes radiology, pathology, and even radiation oncology, such that the level of cancer care delivered in this region of the world can be equal to anywhere else in the world. The third area I'd like to focus on is innovation. Mass General has a long history of scientific innovation that has changed medical care and surgical care once and for all. And surgery is a great example. When Mass General was founded, there was no anesthesia. Surgery was done by simply cutting the affected part out, and the skill of the surgeon was measured not on the precision of the cut, but how fast they could do the operation. A fast operation didn't hurt any less, it just didn't hurt as long. And in fact, the initial ORs were either on the top of the hospital, like our first OR, or in the back of the hospital, because the leadership, the heads of the hospital were scared that the screaming in the OR would scare away the new customers.
Yeah.
And then our first OR, which is now called the Ether Dome, because it housed the first public demonstration of ether anesthesia, which transformed surgery from a barbaric procedure to a careful, precise skill and art. Not only made it more precise because the patient stayed still and didn't scream, but also created a venue for more methodical teaching of other surgeons and created a long tradition of education, which is so important to our history. We hope to take this same spirit of innovation to change how healthcare is delivered on a global stage. And we're doing this through our program of the Consortium for Affordable Medical Technologies, or CAMTECH. CAMTECH brings together entrepreneurs, engineers, and clinicians to come up with impactful, innovative, and commercially viable medical technology to improve health in low and middle income countries. This is different than a lot of public health or global health programs you may hear about because of the word I said a little while ago, commercially viable. Been practicing global health for over 15 years, and I've seen hundreds of great ideas that go nowhere. They go nowhere because even though a great idea that can impact thousands, if not millions, there's no strategy to bring the idea to scale. We believe that there are important markets in low and middle income countries that can scale technology to a global scale in a short period of time. Just witness the cell phone. There is no place, or very few places in the world you can go now without having cell phone access, without the poorest person having communication through a cell phone. That is modern technology that has gone literally viral across the world. We think that there are other opportunities to scale technology to improve health in a very similar way. The CAMTECH process is we bring entrepreneurs, engineers, clinicians together in a 48-hour hackathon where we have clinicians identify the most important public health problems that they think technology can solve. They brainstorm for 48 hours, they come up with ideas, they use those ideas to compete, and the best ideas can compete for an innovation award to move those ideas to our first generation prototype. As we move those ideas to our first generation prototype, the prototypes can be tested in our co-creation labs in India and Uganda in a field setting, in the market and setting where they're intended, or refined. We then put those technologies through a business accelerator to figure out what is the strategy to scale the technology. In doing so, we find corporate partners who want to enter low and middle income markets to identify how that technology will be manufactured, distributed, and scaled. Let me give you two examples of CAMTECH technology. For the first technology, I'd like to go back to the ward at Mbarara, Uganda. This is a ward of 50 beds, often has 75 patients. 1 in 10 of these patients will develop a life-threatening infection. Most common cause for developing life-threatening infection is because a patient got an infection through their healthcare provider who transmitted an infection from another patient. In this 50-bed ward, there is one sink. In that sink, there is no soap, and only some of the time there's running water. It's virtually almost impossible to wash your hands between patients, which explains how infections are transmitted from patient to patient and cause a fair amount of serious morbidity and mortality. Well, the clinicians at a hackathon said, our problem is we need clinicians to sanitize and sterilize their hands between patients without water. So with local innovation, we came up with a hand sanitizer, which we call SaniDrop. I'd like to pass a few of these around and have you give this a try. This is locally produced and manufactured and has gone into field testing with fairly extensive market research in rural Uganda among healthcare providers and also the public. And in our market research, we said in order for someone to actually buy this, and this costs about 10 cents to produce, and the market, we believe, will purchase this for 50 cents, or a 5-fold markup, or profit margin, to pay for the production, supply, distribution, and the profits go and reinvest in the program. But in our market research, we heard two things. One is Ugandans don't like perfume. You have a hand sanitizer, you go to the drugstore, you get a hand sanitizer, it has a little perfume. You're gonna say, my hands aren't clean, they stink. It's dirty in my hands. And then they also said, when you use other hand sanitizers, you know that sticky feeling you get afterwards? Well, feel this one. Let it dry. That sticky feeling is gone. There is no sticky residual. And that is our secret sauce. We believe there's market demand both in healthcare providers as well as the public to buy this product, to scale this product up, but first through locally, regionally, and then nationally, and then hopefully a wider market. Again, the proceeds go back to support the innovators as well as the program. Thus address a very simple solution, but a very effective solution to one of the major public health settings or problems in this setting. The second technology I'd like to share is a bit more high-tech, and this is Dr. Data Santorino. Data is a pediatrician at Bangsberg University in Uganda. And one of Data's jobs is to teach nurse midwives how to resuscitate a newborn baby. There are 1.8 million babies a year who die for lack of that first breath. And 60% of those can be saved through just getting a first breath of air into the baby with a device like this. Looks very simple. Data came to our medical technology hackathon 3 years ago and said, my challenge is to work with nurse midwives to train them how to use this bag valve mask. And we go through a half-day training. I think they get it, but I'm not really sure. But what I'm really worried about is what happens when they go into the field? They just have seconds to a minute to get that baby breathing. How do I know that they're doing it right? And there's 3 problems that can occur to fail to resuscitate a baby. There can be a leak, there can be a plug, or you can go too fast or too slow, with too much pressure or too little pressure. So in this hackathon, Data said, this is my problem. Who can help me fix this? In the audience, there was an MIT automotive engineer. And said, this is a pressure volume problem. I can fix this in my sleep. And he grabbed Data, and he also grabbed Chris Olson, one of our MGH clinicians. And the 3 of them went to Kevin Cedrone's lab. And they developed a first-generation prototype, which they call the Augmented Infant Resuscitator. And here is the 3rd-generation prototype. And this prototype provides red light, green light information on pressure, leakage, and rate to let the clinician know that he or she is ventilating properly. So I practice a fair amount on this. You can see that if you, so I don't quite have it right, slow down, I'm going too fast there. There's 3 green lights. See that? Now if I block it, that shows a red light for blockage. Need to readjust. If I have a leak, it shows that there's a leak. And if I go too fast or too slow, there's lower lights on. Gives the provider instant feedback within seconds that he or she is ventilating a baby properly. This has the potential not only to save lives in rural Africa and India, but also has potential to save lives here. Because not only can a nurse midwife use a device like this to make sure that he or she is ventilating that baby properly in the first 30 seconds, because a delay in 30 seconds leads to a 14% increase in the risk of death. Every second matters. That this device could be in every ambulance in the US, every respiratory therapist that takes someone on or off a ventilator, moves someone to a procedure, be used in every medical and nursing school to train people how to ventilate properly for both adults and children. This is a $175 million a year market. MGH and Bangsberg University co-own the intellectual property for this and are now working with one of the largest medical device companies in the US to figure out a dual market strategy, how to make this available for Africa and India at appropriate pricing so they can go to scale, but also how it can be delivered here in Boston, throughout North America and the US so it can save lives here at home. This is a philosophy of CAMTECH, how an idea from a clinician in rural Uganda can be matched with technology and entrepreneurial expertise to lead to innovation that will save lives, both here and abroad. And so far, CAMTECH has engaged thousands of innovators, 350 organizations, including some of the best medical technology device companies in the world, because they understand their growth market today is India and their growth market tomorrow is Africa, to help develop plans to scale such technology. And we now have a pipeline of 150 technologies, which we're excited about and trying to move this forward to create impact at scale. So I've shared 3 areas where Mass General is striving to have global impact. Disaster response by providing direct patient care where it's needed most. Educating tomorrow's disaster responders and tomorrow's cancer providers for new generations of providers to expand the level and quality of care for generations to come. And technology innovation, to just shake things up and change how medical care is delivered once and for all, both where it's needed most in poor and middle income countries, but also where it's needed here at home. We're very proud of our success, but we could do so much better. There is so much talent at MGH that has yet to be tapped. And you can help. You can talk to your favorite MGH staff member, clinician, nurse, administrator, and you can ask them how they're engaging in global health, because I just shared a few examples, and we're operating in over 50 countries. There's hundreds of great MGH staff that are involved in equally exciting projects. Ask them about their work so we can raise the visibility of MGH Global Health to better approximate our impact. You can also help by accepting the invitation. Come visit one of our programs. Come see what we're doing, meet our partners, bring others, help us communicate our message to identify enthusiasm and support to move these initiatives forward. I think with your help, the 3rd century of MGH can really realize its true global impact. Thank you very much for your time, your attention coming out, and I think we have plenty of time for questions.